Thank you very much. All right. So my disclosures again, which are not relevant. Two more objectives for this talk. The first is we're going to go over the guidelines and evidence for best medical therapy to reduce cardiovascular mortality and limb events related to PAD. And second, apply best medical therapy for the individual patient, whether it be the claudicant or CLTI, acute versus stable disease, and keeping in mind the real virulence of polyvascular disease. So we can break down very simply our treatment goals for PAD into three arms. The first two are to prevent MACE and MAL, which I'm going to focus on during this talk mostly. And the last is to improve symptoms of claudication. In terms of epidemiology and natural history, we heard from Dr. LaRocca about the high burden of disease across the world in patients with PAD. Importantly, this continues to increase. That publication indicated a 26% increase in patients over the age of 65 and 23% in those less than 65. When we think about our patients that do not have CLTI, but either are asymptomatic, atypical leg pain, or intermittent claudicants, about 10 to 20% will have revascularization over 5 years of follow-up, and 1 to 2% will progress to CLTI. 20% will have a non-fatal MI or stroke, and up to a third will die. CLTI, which accounts for about 10% of patients, has a higher morbidity and mortality, so 25% will require limb amputation for limb pain, non-healing wounds, or life-threatening infection within the next year. 25% will experience death due to cardiovascular causes. And this just illustrates how useful the ABI can be, and that it's a predictor for this cardiovascular mortality. So if we look at this bar graph, we see the diagnosis of PADs at an ABI of 0.9, cardiovascular events are on the y-axis, and just having an abnormal ABI gives you a 2% per year rate of cardiovascular events, about 4% per year if it's less than 0.7. If you take that out to 5 years, it's 10% and almost 20% for an ABI less than 0.7. So if we put this risk into terms that people are more familiar with in terms of Framingham, every single patient with PAD is at very high risk. Framingham high risk is 20% at 10 years. We're talking about almost 20% at 5 years for a patient with an ABI less than 0.7, and definitely 20% at 10 years with just an abnormal ABI. Now, there's additive risk for our patients with polyvascular disease. This is a really nice graphic by Aaron Aday in a recent publication looking at kind of the three arms of either cerebrovascular disease, cardiac disease, or PAD, and different outcomes. And these can start to overlap as you have multi-vessel involvement. And if we look at cardiovascular events, coronary events, cerebrovascular events, or PAD events, those with 3 vascular beds, which is the black line, consistently have a higher rate of events. 2 vascular beds should be red here, but it is additive as you have more vessels involved. And what is our guideline-directed medical therapy? Well, we're very lucky to have a lot of level 1 evidence now for a variety of options, including antiplatelet therapy, lipid-lowering therapy, which should be high intensity. We want to get that LDL less than 70. Hypertension, we need to get the systolic blood pressure less than 130/80. The use of an ACE or an ARB to do that has a class 2A indication. Smoking cessation, we should be talking about that every single time with our patients or offering them pharmacotherapy to quit. And then 2 therapies to improve symptoms, cilostazol and supervised exercise. I want to take just a moment to remind you that when the patients are coming to you in the office, they're coming from providers who consider you the expert. Therefore, I would not shunt the responsibility to get these at goal to primary care physicians or other referring physicians. We need to be taking ownership of this. And we're really bad at it. So this is old data, but it still holds true. It's an NHANES data of about 7,500 patients, looking at how well we treated people with statins, ACE and ARBs, and aspirin. Pretty bad, 25 to 30%. And for those patients that did get multiple preventative therapies, there was a 65% lower all-cause mortality. So it works if we use it, and we need to be using it. Thinking about starting with just lipid-lowering therapy for those patients who can't get to an LDL goal of less than 70 with a high-potency statin, there is data to use the PCSK9 inhibitors, specifically in the PAD subgroup from the Peripheral trial. There was a variety of manifestations of PAD, from claudication to amputation, and we can see that in those patients who received evolocumab, there was a significant reduction in cardiovascular events, death, MI, or stroke in patients with PAD as well as without, a number needed to treat of 29. It also improved MACE or MAL in patients with PAD. So a 4.1% absolute risk reduction, number needed to treat of 25 in patients with PAD. There were no safety concerns or adverse events, and the limb benefit persisted even at very low LDL levels. So think about implementing these therapies for your PAD patients in addition to your patients with CAD. I'm going to switch over to antithrombotic therapy, which is a complicated topic. I find this graphic very useful when you're thinking about how to implement therapy for your patients with PAD. If they have asymptomatic disease, I would consider aspirin, especially if they have another vascular bed involved with atherosclerosis. If they're symptomatic, we have very good data for the use of aspirin or low-dose rivaroxaban versus Plavix monotherapy, and I'll go into that in a little bit. And then for patients that have been revascularized after surgical or endovascular therapy, whether or not they get DAPT for 1 to 6 months, we now have data on the use of aspirin with rivaroxaban, I would say over clopidogrel monotherapy. Of course, you need to take into account your patient's bleeding risk. So where does all this data come from? Just very, very broad overview. This is from the ATC trial from 1994. It was looking at various doses of antiplatelet therapy. This other high-risk group is our PAD population. The majority of patients were receiving aspirin in this trial, and there was a 32% reduction in stroke, MI, or vascular death for patients with PAD, as well as other manifestations of atherosclerosis. So this is why we should at least consider aspirin in our patients with PAD. Now, what about the P2Y12 inhibitors? Well, the Capri trial was a large trial looking at patients randomized to aspirin versus clopidogrel. There was an 8.7% overall risk reduction in cardiovascular events out to 3 years of follow-up, and this was largely carried by the PAD subgroup. And that's why for your patients with symptomatic PAD, I would consider clopidogrel monotherapy, again, thinking of them as very high-risk patients over just aspirin. Now, are P2Y12 inhibitors all equal? I mean, we have data from the coronary literature that perhaps ticagrelor is a better agent with a significant reduction in MACE events. And in Plato, this was a non-significant reduction. Well, this was actually tested in the Euclid trial in 2016. They compared ticagrelor versus clopidogrel in patients with symptomatic PAD, and ticagrelor was not superior. So use a P2Y12 inhibitor. And one is not necessarily better than the other. Now, moving over to the COMPASS trial, which was really a landmark study looking at low-dose rivaroxaban, 2.5 milligrams twice a day, rivaroxaban 5 milligrams daily on versus or aspirin alone, and the low-dose rivaroxaban got aspirin in addition, so 2.5 milligrams rivaroxaban with aspirin. This study included PAD patients, and those were defined as either carotid disease greater than or equal to 50% or a prior revascularization, PAD with an abnormal ABI or stenosis greater than 50%. And the trial was actually stopped early at 23 months for superiority in the low-dose rivaroxaban and aspirin group. That's that green line here on the graph. There was a reduction in composite cardiovascular death, stroke, and myocardial infarction with a hazard ratio of 0.72. There was also a significant reduction in major adverse limb events. So hazard ratio of 0.54 in patients receiving low-dose rivaroxaban with aspirin versus aspirin alone. This was offset with a higher bleeding rate, both ISTH major bleeding, which is a pretty conservative definition for bleeding, and bleeding into a critical organ was not significant. So we need to be somewhat cautious in terms of patients with higher bleeding risk, but for those who can tolerate it, absolutely worth using in stable atherosclerotic disease. So when you revascularize, which is really reasonable for patients with inflow disease or those with lifestyle-limiting claudication who have failed conservative therapy and cilostazol in a walking program, or those with critical limb ischemia, how do we handle their medical therapy in that scenario? Classically, dual antiplatelet therapy has been used. It's in the IFUs for drug-eluting stent, drug-coated balloons, atherectomy. This is how these were approved by the governing bodies. But there really is no high-quality data that DAPT is effective in PAD. All of this is extrapolated from the coronary literature. The Charisma trial was looking at high-risk PAD patients, and there was no statistically significant benefit in high-risk patients with stable PAD who received DAPT versus single antiplatelet therapy. Subgroup analyses from the coronary intervention trials have shown reduced ischemic risk at higher rates of bleeding, not surprising. And then we've got 2 intervention trials that unfortunately didn't really answer the question. One was the Camper trial, looking at infrainguinal endovascular therapy, DAPT versus aspirin. It was stopped early due to poor enrollment. And then Casper, which was below-knee bypass that showed no difference in adjudicated ischemic outcomes or bleeding. So that brings us to the Voyager PAD trial, which again was that low-dose rivaroxaban with aspirin versus placebo with aspirin in patients who underwent intervention. And this included about 1/5 of patients with critical limb ischemia, 2/3 had endovascular or hybrid procedures, and the median ABI was 0.56. The primary outcome was cardiovascular death, acute limb ischemia, major amputation, or stroke. And you can see that there was a significant reduction in that blue box, which was the rivaroxaban with aspirin group. It also reduced acute limb ischemia, 5.2% versus 7.8% in placebo, at a higher risk of bleeding. There was no incremental benefit with the addition of clopidogrel. Higher bleeding was noticed with clopidogrel more than 30 days. So about 50% of the patients in this trial had clopidogrel on top of whatever therapy they were randomized to. You can see the Kaplan-Meier curve for patients on clopidogrel versus without. There was no difference in the absolute risk reduction between the 2 groups. So we should not be withholding low-dose rivaroxaban to our patients who are getting DAPT with their revascularization procedures. You can give them Plavix or clopidogrel for anywhere, ideally up to 1 month without any concern for increased risk of bleeding, but up to 6 months if you're willing to take that risk. I would just make a comment before I get into my summary remarks because I have time. I think it's going to be less about the question of DAPT versus low-dose rivaroxaban with aspirin going forward. I think it's more going to be definitely low-dose rivaroxaban with what antiplatelet therapy and for how long. So for example, should we be using clopidogrel with low-dose rivaroxaban? And I think that's where the space is going to be moving in the future. In summary, patients with PAD have a very high cardiovascular morbidity and mortality. The risk rivals coronary disease and cerebrovascular disease, and the risk is even higher in our patients with polyvascular disease. We need to keep that in mind. Optimal medical therapy for PAD reduces death, MACE, and MAL. Please prescribe them. You can't go to war without a weapon. Thank you.